Welcome to Second Opinion. Clinical investigators provide perspectives on the role of AKT inhibition in the management of prostate cancer. This is medical oncologist Dr. Neil Love. On February 27th at the 2026 GU Cancer Symposium in San Francisco, we held a CME meeting moderated by Dr. Elisabeth Heath from the Mayo Clinic in Rochester, Minnesota, with faculty members Dr. Karim Fizazi from the Center Oscar Lambret in Lille, France, and Dr. Dan George from the Duke Cancer Institute in Durham, North Carolina. Included in the meeting were a series of pre-recorded video case presentations with Dr. Neeraj Agarwal from the Huntsman Cancer Institute in Salt Lake City, Utah, and Dr. Rana R McKay from the Moores Cancer Center in San Diego, California, who met with me prior to the meeting. These cases were discussed by the faculty panel, beginning with some questions from Dr. Agarwal.
These are the questions for Dr. George, because according to his session, biology, testing, and clinical relevance. How early in prostate tumorigenesis does PTEN loss occur? And do you view this primarily as an initiating event or a driver of disease progression? Clinically, how strong does PTEN loss correlate with aggressive phenotype compared with other biomarkers such as BRCA2 or TP53? Should PTEN deficiency be thought of as a prognostic marker or predictive marker or both? What is the real-world frequency of PTEN loss in localized disease versus metastatic disease? How often do you see intra-patient heterogeneity when PTEN status differs between the primary tumor and metastasis? In 2026, what is the most practical way to assess PTEN loss in routine practice? Is it IHC, tumor NGS, or ctDNA testing? Should PTEN testing be done at diagnosis of metastatic disease or only when considering targeted therapy? How does PTEN loss influence your treatment thinking today, even before AKT inhibitors are fully integrated, assuming they are approved? Do you see PTEN status becoming a standard biomarker like HRR mutation testing? Mechanistically speaking, why is PTEN loss such a strong rationale for targeting the PI3 AKT mTOR pathway? Do you think PTEN deficient disease represent a distinct biological subtype that should be managed differently?
Okay, the good news for the audience is we're not going to tackle all of those 40 questions this evening, but I think that's just a semblance of what we're probably all thinking about this new path. How do we actually operationalize these things? So why don't we take a few of what Neeraj has tossed our way, and maybe we'll take the first one. So, Dan, specifically here, how early in this prostate tumorigenesis do you think PTEN loss occurs, as you've mentioned in one of your slides? And do you think this is a primarily initiating event or as a driver?
And before maybe Dan answers,
please.
Neeraj forgot one question, but
yes.
Dan will answer for sure. Yeah. Does God exist? But maybe come back to
that's
Peter.
just all under in the subtext.
Yes,
Okay.
yes.
Absolutely.
No, yeah, it's a lot to unpack there. But let's start at the beginning, because I think it's a really important point.
Yeah.
Because PTEN loss is something we see really early on. I mentioned in this Gleason 1 cancer, grade group 1 cancer, we can see loss of PTEN. It's probably not the initiating event. It's probably one of the events that's associated with the progression of this disease. And that's what we see throughout the course of this natural history of prostate cancer, that loss of PTEN is associated with a more rapid growth and transition, whether it be by grade, by stage, and ultimately by disease state. So I think of it as being associated more with progressive disease. It's really difficult to determine, carcinogenesis in this case, but I think primarily that's driven through androgen receptor biology in the vast majority of cases.
No, I think that's really great. Maybe sort of the third question here is, I think you mentioned this in one of your slides, just so it's ingrained in our minds, it's just what's the frequency of this PTEN deficiency, in localized versus metastatic disease?
Yeah,
we're certainly
I kind of
used to
some
that.
of that. Yeah, I showed some of that. So
yes, you did.
It's nuanced because it depends on what level of PTEN deficiency you're going to use. Karim's going to show you a study where we used a 90% threshold cutoff for loss of PTEN. If you lowered that to 50%, you'd see a higher level. So that's why I think the literature is highly variable in this aspect. But the truth is that this is happening even at relatively low levels or heterogeneous loss of PTEN gene expression, probably in many more prostate cancers than we're recognizing. To what extent that sort of partial loss is biologically active, we don't know. But as I said, as a phosphatase, the relatively lower levels of this are going to lead to a relative shift of activity. It's really the more complete loss that really turns that pathway on constitutively. And it's why, we focused in clinical trials on the very high deficiency of this, why that matters most.
Yeah. Well, and I think the concept of testing, as you mentioned, whether it's molecular testing, immunohistochemistry, we as practicing clinicians want to know what's the optimal method to assess PTEN status. Yeah. When should this testing be done? Should it become relevant when this path either moves forward or doesn't? But I think the audience wants to know that as well. As Neeraj.
I'll tell you that what's been tried and true and studied for a long time is immunohistochemistry. There's also FISH, and I showed one slide with some of that where we can kind of look at the nuclear chromosomal level of that gene present, but probably what's newest is genetic testing or next-gen sequencing of multi-gene tools like we see with like Foundation or Caris or Tempest. So to me, I think recognizing these as different modalities of assessing PTEN, but immunohistochemistry been around the longest, is the direct measure of the protein. That's the activating form. That's what's probably most important. It's something that can be done on the least amount of tissue. So even these small biopsies where we're getting a millimeter or so of cancer sometimes, we can pick that up in. And it's also something that I think at the end of the day is scalable and affordable, can be done in a day versus being able to send these blocks off, waiting for pathology to ship it somewhere and get those results back. So it's not to say that next-gen sequencing isn't important. When we do see genetic loss, that's going to translate into the immunohistochemistry. It's about 90% concordance that way. When we see differences in immunohistochemistry, it's not always shown up in the genetic loss because there are other ways of knocking out the gene. So there is a little bit of discordance, but for the most part, this high level of PTEN loss in immunohistochemistry is going to correlate with the genetic loss that we see on next-gen sequencing.
When do you think that testing should be done, though?
So personally, I think there's value in it in any level of prostate cancer, but probably going to be most important in these high-risk or metastatic cases. So to me, when I have somebody with a metastatic prostate cancer, this is something we want to know because I think we're beginning to appreciate, and the study that Karim's going to show us, Capitella 281, really drives home prospectively for the first time what this biology of PTEN deficiency looks like in a large prospective trial with and without targeted therapy for it.
Well, lest the audience think there's no more questions, let us then switch to Rana McKay's questions. So she's got a handful as well in her conversation with Dr. Love.
Dr. McKay formulated her queries for the faculty related to cases from her practice, beginning with a 69-year-old man with hormone-sensitive recurrent metastatic disease after primary radiation therapy previously.
He was found to have PTEN loss, homozygous deletion, on the NGS testing on his archival primary tissue specimen from back in 2017 from his biopsy near diagnosis. At the time that he actually was diagnosed with metastatic disease, his PSA was only 10 and testosterone was 357 when imaging demonstrated multiple bony lesions, the rib, left scapula, T1, L3 sacrum, and also adenopathy. And he also had retroperitoneal and like a left supraclav node. I think this kind of speaks to the discordance a little bit of PSA with PTEN loss.
And I'm just kind of curious, let's say you could access capivasertib. Do you think he would be inclined to be wanted treated or not?
It's a possibility. I think individuals that are a throw the kitchen sink at me doc type people are generally individuals that I think are well suited for escalated therapy, and escalated therapy that comes at a cost. This individual is incredibly high functioning. The leuprolide and abiraterone that he's on do not really negatively impact his ability to do his activities of daily living. He works as an executive. If this individual presented today like this, and we actually had capivasertib that was approved and available for us to potentially use, I would absolutely discuss the treatment options and go through the pros and cons. And I would propose to the faculty, what would you do in this scenario?
Right at you, Dan. What would you do in this scenario?
So we're going to see this data in a little bit, and I think what you're going to see is that this is a poor prognostic patient. Even though he's tolerating the hormonal therapy well, even though his PSA is responding, I'm concerned that PSA is not enough in these circumstances. That these are the patients, he already had a low PSA to begin with. These are the patients that are at high risk for developing disease progression independent of a PSA rise. Not to say the PSA is completely zero, maybe low, but it's not rapidly rising as the first sign of castration resistance. And that's what we typically see when we're using, these androgen receptor pathway inhibitors in ADT. And what we see differently in the Capitello 281 study is this discordance. And I think it's an indication of this AKT pathway, because again, this isn't activating the PSA gene the way androgen receptor does. So with growth and proliferation driven through the PI3 kinase AKT pathway, we would expect disease progression without necessarily a significant rise in PSA, and we see that. So I'm concerned, even though this patient's responding, he's tolerating his abiraterone well, he's a good candidate to treat with capivasertib. And I would absolutely want to talk to him and discuss that option with him.
I wonder, Karim, have you encountered patients with aggressive disease that ended up being from PTEN deficiency, kind of seeing that low PSA? I think we all know to look for that when you have an imbalance of the imaging versus what the PSA is. Have you seen that in your practice?
Yes, obviously, yes. And not to say that all patients with PTEN deficiency don't have high PSA, for example, or baseline. If they have de novo metastatic disease, they might actually. It's more during the course of a disease that indeed, as Dan just said, when they tend to progress with a cancer growing, the PSA either will remain low or sometimes even zero. So that exists. It's not necessarily only PTEN deficiency cancers. We also see this phenomenon when neuroendocrine differentiation occurs. But clearly, this is a phenomenon we saw more frequently in the trial, for example, in this population of patients with PTEN deficiency. Again, not saying that there is no rise at all in the PSA, but it's not necessarily reaching the classical 25% increase and greater than 2 nanogram per ml. It's again slower and milder, I guess.
Yeah, it's a little different pattern of recognition. I think that's something that we may have to get used to in the future. Raina's other question is, I guess we'll start with you, Karim. If the drug was available, is that an appropriate option on the basis of NGS testing, or is that good enough on archival tissue? Would you have to do a metastatic biopsy? And especially you're not in the U.S. in practice. What would you think about that from an international standpoint?
Sure. Those are important considerations with regards to, many things, cost, but also patient convenience. For example, if you need to rebiopsy. It appears that archival tissue is mostly informative. So that's important. And same for BRCA alterations, for example. And I would say the exact opposite when it comes to androgen receptor mutations, which typically occur under therapeutic pressure. So here again, if your patient was diagnosed, say 3 years ago, he had a local treatment and then he relapsed with metastatic disease, you can mostly trust the archival biopsies or prostatectomy specimen, which makes all our life easier. Now, in some cases, simply the archival tissue is not any longer useful just because it was harvested a long time ago, and so you cannot use it any longer. So that's very important to know. Now, between the discussion also between immunohistochemistry and NGS, that I think was very clear about it. Mm-hmm. If you set the cutoff quite high with the immunohistochemistry, you're covering most of the NGS information. So greater than 90%, which we use in the trial, didn't come from nowhere. We had internal data, but also external data, supporting quite a great correlation between this cutoff and the NGS findings. And when we set the trial, we actually discussed whether we should go for one or the other. Mm-hmm. Immunohistochemistry is much easier, of course, and much cheaper. So if successful, it can be used in many places worldwide to address your question, while NGS remains quite expensive at many places.
Subsequent to the recording of this program, the FDA approved capivasertib in combination with abiraterone and prednisone for adults with metastatic androgen pathway modulator naive or sensitive prostate cancer that is PTEN deficient as detected by an FDA-authorized test. Please check out the official prescribing information for more. This concludes our program. Special thanks to our faculty and to our case presenters, and thank you for tuning in. This is Dr. Neil Love for A Second Opinion. Clinical investigators provide perspectives on the role of AKT inhibition in the management of prostate cancer.